I'm going to present to you on a model of care that we have developed in Queensland of providing treatment for people with hepatitis C. My presentation this morning will cover 4 areas. There's some context and some epidemiology that I'm going to go through briefly in the beginning, and you may think I'm taking you on a bit of a tourism guide of Australia. It's not that. It's more to give you some information about telling you some of the factors that influence how we deliver care in Queensland. I'll then concentrate the main section of my talk on the 3rd section there, the patient model of care that we've developed, and then I'd like to talk a little bit in the end about our community support. China, as you've just gathered, a very large country with a very big population. Australia is a large country, but we have a very small population, 22 million approximately, and if we wanted to take the UK and fit it into Australia, we could do that 32 times. So that gives you a bit of an idea of the scale that we're dealing with. I stopped yesterday to have a cup of coffee, and a very nice Brazilian chap served me coffee and had a little bit of a chat and asked me where I was from, and he said that we had very big deserts in Australia. Thought he was talking about the obesity problem, but obviously what he meant was the desert that we have in the middle. So yes, we do have a very, very large desert. We have also a very interesting mix in our population now. We have our Indigenous Australians, the original owners of our land, comprise 2.5% of the population. Now, the population in Australia gravitate, as you may well understand, away from the deserts or the deserts to the coastline. So we have a very, very big urban population. So this has quite a large impact in terms of delivering services. And 85% of our population, approximately, live very close to the coast, within about 30 miles, 50 kilometres, whichever way you'd like to look at it. 17% of our population comes from a non-English speaking background. And we know that we've got at least about 40% of the people are from a mixed cultural origin. Now, that presents for us a number of issues when it comes to delivering culturally appropriate services. We need to make sure that we're showing respect and regard for their cultural mores and tenets, and there is a communication barrier there as well. 226 languages are spoken in Australia. A large number of these are obviously the Aboriginal languages that we have, but nonetheless we have a large number of people from different countries, and we need to cater for that, and we need to acknowledge that. Our system of government in Australia, we have 3 tiers of government, and the reason I'm mentioning this is that obviously the distribution of taking care of people and the funding for that comes through in different levels. So we have a federal system, and we have our state system, and then we have local government. With our health system in Australia, it's similar to the NHS in some regards, but we have a very big number of people that will go through a private system. Now, by that what I mean is people will take up private health insurance to go and secure their care. What this does, and the aim of it, of course, is that people over a certain wage level or income level will often go to get private health insurance. They're subsidised by the government to do that and encouraged to do that, freeing up the public healthcare system for a large number of people. We know that a lot of our people that have hepatitis C come from very marginalised groups, so this works for us. Strategies, you may be familiar that Australia has had 3 national strategies now addressing hepatitis C, and the new one is currently being developed, and hopefully that will be out next year. There we have our systems, basically our healthcare system. If you hear me referring throughout the talk to Medicare, similar to the NHS, it's the public system that I'm talking about. Queensland, the state now that I live in, is, as you can see in the corner there, the red section of Australia. It's a very large state. It's the 2nd largest state, and it has a population of approximately 4.2 million. Now, this is probably one of the major factors that's influenced our patient care. A lot of the population, again, are centred along the coastline and also in that southeast corner. So a lot of the people that we know that have hepatitis C also live inland and in rural areas. But to get to these centres for treatment, it's a very, very long trip for a lot of people. So this is Brisbane. It's a very large city. We have approximately 1.1 million people residing there. We have 4 very large hospitals. These are tertiary hospitals. One of them is so big it has its own postcode, so that's a very, very big complex. A lot of people live there, but they're spread throughout other cities. This is a typical small town in Queensland. You can see there are services there. There is bus, there's garbage collection, there's postage, etc. No major hospitals, no major medical facilities. Coca-Cola's got its tentacles there, as you can see as well. There are some other towns where people live basically a one-street town. That's all there is. They need to drive a long way to access services. Our Indigenous population, 3.2% of our population is Indigenous. We know that throughout Australia, hepatitis C is quite an issue for the Indigenous people. We know that there's approximately 16,000 Aboriginal people, Aboriginal and Torres Strait Islander descent, who have chronic hepatitis C. Accessing the numbers for these people, getting these people to go into treatment is another challenge for us. Our national strategy, as I've mentioned previously, it has a major focus on improving access to treatment and uptake. Our state strategy reflects this as well. Programs that we've developed, and the program I'm about to launch into talking about in a bit more detail now, is reflected in this strategy. It's a key thing that we've been asked to make sure that we have anything that we develop is evidence-based. Moving on to our epidemiology. So to get the big picture in Australia, we have 212,000 people living with chronic hepatitis C. That's a significant number. For a country with a small population, that's a large number of people to be looking at. Just under 50,000, 49,700, have moderate to severe disease, and we have 5,700 with cirrhosis. What we've had that's happened in the past is that we've seen a nice decline in the number of people that have hepatitis C. You can see those two top lines, and the graph is showing that the rate is coming down. So the main majority of people in that cohort there that have hepatitis C as well, the age group there is the 20 to 39 year age group. So that's where we know we have a lot of people with hepatitis C. Moving on to Queensland, our prevalence there is about 1 to 2.3 of the whole population. Again, we've got a much higher prevalence in high-risk groups, so people that are incarcerated, people in prisons and injecting drug users. Just a little bit here about our liver transplants. They don't separate out the data here between Australia and New Zealand, so don't go getting an idea we've merged. We haven't. We're quite separate still. Basically, 3,076 liver transplants per year are carried out. 27.7 of these are hepatitis C related. Obviously, the end cost and the trauma and the morbidity associated with that for people is significant. So we want to avoid people getting to that stage. In 2006, we had a projections working group. So major epidemiologists and mathematicians got together, and they knew that we had to do something about this issue of people accessing treatment. The stunning news for all of us, particularly working in government, was that we had to triple the amount of people going through treatment if we were going to start to make any dent on this issue. So for us, it wasn't so much a wake-up call, but we knew we had a lot of hard work ahead of us. So if I have hepatitis C and I live in Australia, I have two options. I can go through a private system, which brings with it some benefits. I can select my own specialist. I probably will get in quite quickly for treatment, and I will have probably a very lighter wallet at the end of it. It will cost me a lot more. The public system, a system that we operate at Queensland Health, provides for people that aren't able to afford a private system, and they can receive their treatment as well. They may have a longer waiting time. They'll have a much less impact in terms of finance. So in 1999, we knew that there was a major issue at our doorstep. We knew there was this tsunami of hepatitis C coming through, and we knew the numbers were rising. So we sat down and we had to do something about it. We knew that we didn't have very good resources. We weren't set up very well for people that had hepatitis C. Some of the people coming to hospitals had to go into an outpatient section. There wasn't a dedicated liver clinic, and we knew this was a problem. We also knew that people had to have a liver biopsy, and we knew that put people off going for treatment. At that stage, we're treating about 200 people per year. So we developed an initiative. It's called a Shared Care Initiative. And as the words might sound, it's basically what it says. We share the care of the patient between their local doctor and a multidisciplinary team at the public hospital. We piloted this. We ran a pilot that took about a year in the major tertiary hospital in Brisbane, and it was viable. We did an economic analysis as well, and it showed that it was something that worked. More importantly, it worked for the patient. We put in some submissions. We weren't successful on 2 occasions for that. We were hijacked by a nurses' strike and a couple of other things that are always there. But we had our breakthrough in 2006, and we secured funding. So the aim of this model that we had developed, it was basically to increase the number of people going through treatment. That was our long-term goal. And it was based on a premise, and the premise was that we were able to share the care of the patient. It could be done effectively and according to some protocols by sharing the care between the local doctor or GP and a team at the hospital.